The July deadline for junior doctors to begin their compulsory one-year community service is fast approaching, but many still anxiously awaiting to be allocated a spot despite a shortage of doctors in the country. We're now joined by the South African Medical Association Trade Union General Secretary Cedric Sihlangu. Cedric, good evening to you. Firstly, how big is the problem of doctors that haven't been placed? And you can give us the numbers here. How many people are affected?
Okay, good evening, and good evening to your viewers as well. But perhaps to give a bit of perspective as to why this issue of interns and community service doctor placements is such a contentious one, is because it's a statutory requirement. You know, for you to qualify and be independent practitioner as a doctor, you've got to go through your internship and community service. But unlike our colleagues in, for example, the legal profession, where they can do their articles of clerkship in a private practice or their pupillage with a private practitioner, advocate. With doctors, unfortunately, you can only do it in the public service, in a public funded, government post. So as a result, this causes a lot of anxiety to our junior doctors, especially primarily because it's a biannual placement process. So they get placed either on the 1st of January to start on the 1st of July. So in between, you've got a lot of doctors who then sit idle waiting to start according to perhaps the next placement. So in this instance, every year you'd look at about just over 2,000 placements that need to be made. So fortunately, this time around, quite a number of placements have been made, and there was only a small portion of ComServes that were still unplaced as of last week. It was about 18 total. We've worked very close with the Department of Health, the ICSP program manager, and we've tried to ensure that almost every doctor is placed, to the extent that I can quite confirm now that as of perhaps an hour ago, we've got confirmation that almost everyone has been placed, except for the few where there are just glitches here and there. But we've tried to push quite substantially to ensure that we meet the July deadline of the 1st of July, but there might be a few that start in the 1st of August.
Well, that's certainly encouraging, Cedric. One of the challenges that this program often faces is the fact that, many of these interns are sent to not just your urban areas, but especially your rural areas where there are lack of resources. And many come out of the experience feeling that they weren't well supported for the work that they needed to do in the communities that they were serving.
Look, that's the unfortunate truth of the current situation in the country, that where the help is required the most, that's in the villages and the rural areas, there are very few senior doctors. What tends to happen is once a doctor is an independent practitioner, they move back to the urban areas. Some of them go to private practice and they serve a minute subsegment of the population, which is those who can afford private health care. So the doctors who go to these far-flung communities in the rural areas, those who are actually mandated to serve the community service here, do find themselves sometimes, or in most instances, in fact, under-supported because of just the lack of senior doctors in those centers to support them.
How do you think an issue like that can be resolved? Because this is also part of a learning experience for the young doctors, and those seniors being there is not only to oversee the work that they're doing, but also to help transfer some of those critical skills that they'll need going into the rest of their careers.
Our view, Kathy, is we probably got to start imagining a system overhaul where we reimagine the training and the graduation of doctors and how they interact with the population at large. And perhaps we hope that the NHI might be such a probability where we end up having a situation where both the private and the public almost come to a point of merging, where you'll have equitable distribution of skills. And when you do that, that means that the exposure of these junior doctors will be quite spread out, as opposed to now where the moment you finish your community service, you jump and start your private GP practice, and you're no longer accessible to these young doctors.
And let's talk about that success rate then. What are you seeing for the doctors who finish their year of community service? Are many of them ready to actually be running their own practices? And I know that it doesn't necessarily mean that it stops them from doing that, but are they actually ready to be doing that?
Look, I think I'm comfortable with our training in terms of South Africa. When you go through your medical school training, you go through your internship training, and by the time you're done your community service, you are truly an independent practitioner, meaning that we could safely say that you are safe to practice independently. That's really what it means, and that's why the regulator is so confident to say, after you've completed your community service, we are safe for you to work independently, whether it's in a government facility, whether it's in a private facility. Of course, there are those who prefer to stay in the government facility. There are those who prefer to go back to school and specialize, but there will be a subset that prefers to rather start their own GP practice. And invariably, they all are serving the same population. That's the South African population.
All right, we'll leave it there for tonight. Cedric Sihlangu is the South African Medical Association Trade Union General Secretary.